I'm Sherwin Hua. I'm a neurosurgeon, and I do about 90% spine. And of that 90%, about 70 to 80% is done at an ASC. And today I'll talk about integrating spine surgery into the ASC. First, just a disclaimer. I'm also going to show some pictures of the San Francisco Bay Area where I work. This is, of course, the iconic Alcatraz and the Bay, and disclosures. I work on a system that is able to do minimally invasive spine surgery through a very small incision. I also work with some spinal robotics companies. So my ASC journey, I have a focus or interest in minimally invasive spine surgery. Starting after residency in 2005, started using the metric system from Medtronic, and that's pretty much the standard. I also have a very big interest in neuromodulation, which is spinal cord stimulation. And from that, it's actually ideally fitted for ASC situation, outpatient surgery. I started also doing very minimally invasive T-lifts, which is lumbar transforaminal fusions with pedicle screws. So I started doing them with very small incisions, 18 millimeter dime-sized incisions in 2008. That's in the hospital setting. And it basically took 10 years to then finally try it in the ASC setting in 2018. And since then, I've done 1, 2-level, and actually 2-level plus maybe a 3rd level too. So it's become pretty comfortable doing the lumbar fusions in an ASC setting. In addition, been doing 1, 2, and 3-level cervical discectomies with total disc replacement or fusions. And most recently, been doing the endoscopic surgeries with either JoyMax or Eloquence. And then lastly, SI fusion, I think, which is also a good surgery for ASC. So important thing is patient selection, because some of these surgeries can be pretty big. We work with the anesthesia group to determine who are good and bad candidates. I think BMI is pretty important, as well as sleep apnea, cardiac, and age, as well as previous narcotic opiate tolerance for the outpatient pain management. I'm also going to now discuss the different categories that I group the different surgeries. Some are easier, but some are harder. They also go with length of surgery in general, what are easier surgeries to do, and that also reflects what are easier and harder surgeries to do at an ASC. So the easiest surgeries to do at ASC are the awake and percutaneous types of procedures, like spinal cord stimulation. That's something that pain management doctors do. I also do them for the trials and the percutaneous permanent implants. JoyMax is the endoscopic surgery, so 1-level extruded disc or a metric disc discectomy. Those are very standard. And the SI fusion, although that's quite painful, but you can reduce it, and I think it's a great surgery for ASC setting. And these are, I think, a great way to get started. I think most surgeons can do these pretty easily. Medium procedures, these are a lot of the bread and butter surgeries, other than the spinal cord stimulator paddle. So the paddle or laminectomy implant, I do awake with a small laminotomy opening. I think that works very well. Then you have the foraminotomies, which are very bread and butter, 1 and 2 levels with or without a coflex, which is an interspinous non-fusion implant. I think those are all pretty popular and very common. Now, cervical 1 and 2 level cervical discectomy or fusions or disc replacements now I think are very straightforward. There's one center that requires overnight stay, but most of them they just leave after 1 or 2 days, 1 or 2 hours. JoyMax is the endoscopic 2-level. Sometimes can be take a long time if there's a lot of bone spurs and osteophytes. The harder procedures, such as this is the picture of the Lombard Street in San Francisco. These are the implant procedures. They take longer. They're more painful. They're the 1-level, 2-level T-lifts, the lumbar fusions, the X-lifts from the lateral position, posterior lumbar fusion, which is just pedicle screws. Also, 3-level lumbar foraminotomy. These are just more levels, so it's more pain. 3-level cervical disc replacement. And then there are surgeries I haven't done yet at ASC, but I know other people have. So awake T-lift, I think the key to that is you need to get the T-lift down to about an hour and a half. I'm probably down to about 2.5 hours. 3-level T-lift, that I probably would consider that. 4-level cervical TDR or fusion, I probably could do that. The ASC just haven't done it. And an A-lift from the front, I think there's risk for vascular injury. I know people who do it, especially at L5-S1, but I'm more of a posterior guy. So in terms of tricks for ASC, I put the image of Apple Computer and their spaceship because I think Apple is a good example of having a very good patient experience. So you want to have the patient to have a good experience during the surgery, minimize pain, and also transition to the home setting. If you can do that, then they'll be happy. So awake surgery, I think, is helpful because when they're awake, then and use local, then you can ensure that the pain areas are covered. Now with Exparel, which is liposomal bupivacaine, it can last 2 or 3 days instead of 3-4 hours, and so I think that's very helpful. But you're limited to only 20 cc's per patient. So then I think a small incision is helpful both for recovery and for also maximizing your Exparel in that incision. Lastly, for the bigger procedures, I also give them an epidural, which covers probably 6 to 12 hours after surgery, and a lot of them after a T-lift, 1 or 2 level, they wake up and they don't have very much pain. I give them post-op narcotics, and for me in my practice, I give them my personal cell phone so that I ensure that there's no problems. If they have any problems at all, they can give me a call. Most of them don't call me, but it's just the reassurance that they don't call an answering service and they can't reach somebody, and then they take the patient to the ER. So how do you get started with the spine program? I think a good anesthesia group, I think, is very important. And then a good table. I think some of the older tables, even with something like spinal cord stimulation, where if you put them on a Wilson frame, you have all the gears and the fluoro is a mess, or a SI fusion, where you have to really do the inlet outlet views, and it's very hard with that base in the bottom, to actually a lumbar fusion, where a table, I think, is very important. Then the drill, microscope, and then you have to decide whether you want to try the endoscopic types of procedures, because those are pretty high capital costs. In terms of getting the equipment, well, buying the new equipment, of course, is ideal, but very costly. You can also have financing and leasing options. I would just be careful buying online because usually equipment in a surgery center needs a service contract. Mitsubishi OSI actually has a pre-owned service contract equipment program that I think would have the best of both worlds. This is the last slide, just for the centers that I go to. Some of them have a Jackson table, but I really like the Pro-Axis table because it allows me the very fine tuning of the flexion extension, which is very helpful for a lumbar fusion instead of compressing the screws at the very end, but also inflection to open up the lumbar spine for decompression, placement of Coflex, and then eventually for the pedicle screw fusion. Also, I think navigation may be something to that would be interesting in the future. Thanks.